Okay, so today we're going to talk about chapter 4, vascular structures, which is like a huge chapter, and this PowerPoint is 134 pages, or yeah, pages, slides. So if I talked about every single slide, I would be talking for like 2 hours. So with this chapter, it's going to be really important that you're reading this chapter, um, that you are really looking at your workbook. This chapter does a great job of explaining in detail all the vascular structures of the abdomen and just some things that can go wrong. So I'm going to just touch on like a couple of things and try to make it short and sweet so you can really um, use your time, which I think is going to be the best of your ability is to like read this chapter. But yeah, we'll go over a couple of things. So let's start with the vascular structure. So when you're like starting abdomen, you're going to be scanning probably like the aorta. Um, you're going to see a lot of vessels. And so it's really important that we are learning how to identify these vessels. They're going to be really important for you. And so I'm going to touch on the stuff that I feel like for right now you need to know. There's a lot of pathology that happens in the vascular structures in the abdomen, and those are also really important for you to know. But as we're starting out, it can be a little overwhelming when you like look at this chapter and you're like, oh my gosh, I got to know this all day. I'm like, you do got to be aware. But let's talk about the stuff that you really need to know as you're first getting started. So let's go if I can get this going. So this is just the objectives, which, we're going to learn some pathology, etiology, clinical signs and symptoms, sonographic appearance of different venous and um, artery pathology. This is how the chapter is lined out. So patient prep, most of the times, and especially when you start scanning the abdomen, we want the patient to be NPO. So NPO means they haven't eaten anything for at least 6 hours. This is going to help with bowel gas, especially if you're looking at like renal arteries and the aorta. If you don't have like a lot of food in your system and you don't have bowel gas, because remember ultrasound can't go through bowel gas that well, it's going to be just an easier study. So we just usually like patient is NPO after midnight or something like that, and then in the morning is when we scan. Sometimes in some studies they want the patient to eat afterwards so we can see like the vascular flow of like the SMA, which is what we're going to go over today, how it's affected by meals. So this is just pretty straightforward stuff. Okay, here we go. So systemic circulation, probably from your anatomy and physiology, you know that arteries transport blood from the heart to the muscles and organs, and veins transport blood from the muscles and organs back to the heart. So the blood vessels have three distinct layers: the tunica intima, media, and adventitia. I don't know. I've never been able to say this word adventitia. You guys would probably do it better than me. But it has the three layers. I know how to spell it. And you need to know that. You need to know what arteries and veins do, and you need to know that they have three distinct layers. So, like with the difference with the arteries and veins, which is also important as you're getting started, like the arteries, the walls have like a thicker and they tend to maintain their constant shape. So they don't readily collapse. Now, vein walls, on the other hand, they're less smooth muscle and less elastic tissue. So they're more like can be collapsed easily if there's not a clot in them. They're unable to contract to force blood flow, and it requires pressure gradient and breathing and skeletal muscle contractions to get the blood out there. So it's more of a slow flow while the artery is like like more of a hard pressure flow. This vascular anatomy, you should know this from your anatomy physiology class, but just to go over it again, the ascending aorta, you're going to have the aortic arch, the descending thoracic and abdominal aorta. This is really important. You can see all this fun stuff coming on down in the abdomen, past the diaphragm. You can see all those trunks. And so that's what we're going to kind of talk about today, or all those different arteries coming off of the abdominal aorta. Okay, so this is the things that you really do need to know and they could be quizzed on. So you're going to have your celiac trunk. The left gastric artery is going to come off, right? Or right after that. And then you're going to have the split of the common hepatic artery and the splenic artery. So I want you guys to know the celiac trunk. The renal arteries, you can see right and left renal, they come off the sides. And then you're going to have your superior mesenteric artery that comes off right before the renal artery. So everything's kind of splitting pretty fast. Then you have other arteries coming off, and like the inferior mesenteric artery. But these are going to be our important ones that we want to look at today. So I'm going to let you look at this for a second. This is a transverse view. So this is the level of the transverse section at the celiac axis. So you can kind of see like it's A on this body here. So it's a cut straight there. And so this is what it looks like, not on ultrasound, but like on a diagram. So you can see the aorta, and then you can see the celiac axis coming up there. And then you can see it split. And this is what it looks like on ultrasound right next to it in black and white. This level of transverse section is made through the pancreas. So it's just a little bit below A. And you're going to see that what we're looking at here is the aorta and the SMA. Next up, this is a long section. So if you can see on the person and see, this is how we're cutting when we're looking, we're doing a sagittal image. And this is seeing it from a different way. So this is like if you're cutting it long ways and you're looking at it. So the aorta, celiac trunk right here, and then the SMA is coming off right next below it. And I think these are very helpful. And the picture A, this is a long aorta, again, like a sagittal view. And the long plane through the proximal aorta demonstrates the celiac axis, which is the first vessel coming off, and the superior mesenteric artery. And then the L is the liver that is on top, anterior to the aorta. And vertebral bodies, the VB, are in the bottom. So this top of the screen is anterior, correct? And the bottom of the screen is posterior. So this is a patient that is in a right lateral decubitus, so laying on their right side. The long plane demonstrates the bifurcation of the aorta into the right and left common iliac. So it's looking from a different view. This is again the level of the celiac axis. You can see it kind of looks like a bird or a swan to me coming off. That's what we kind of like to say. And then the IVC and the aorta are right next to it. And this is below that. This is going to be the level of where the right renal artery and the left renal artery come off the aorta. And look how small they are. And thinking about how big the aorta is compared to those little vessels, but how important they are to give us the blood to our kidneys. This is like a coronal view. So I'd say like if you're cutting across, um, I would lay the patient on like a left side and then I would scan from the side. This is how it's going to look. We call this the banana peel sign, and it's going to be the aorta and the left and the right renal arteries coming off there. Look like a banana peel. Nutcracker phenomenon is a pathology that we'll go over that when the SMA and the aorta um, pinch the left renal vein. It's pretty rare. The IVC, this is what an IVC looks like. You can tell that it's like more like just not as hard of appearance as an aorta. It kind of like there's some smaller parts and there's some bigger parts because it's kind of phasic more. But it kind of looks like a hockey stick as it goes through the liver. So veins are also around that we need to know about. So the abdominal veins, really important, the right, middle, and left hepatic veins. That's a big one. Then below that, we have the splenic vein, which is pretty important. And it from the spleen and the portal confluence into the liver. And you'll have both the portal vein that goes into the liver and the right renal vein. Then you'll have the left renal vein on the other side, and then the superior mesenteric vein. For some reason, I don't know exactly why, but I love like what the veins look like in the liver. So this image on A is like a transverse section. And you have the patient like breathe in. That's what I usually do. And then when I breathe in and it's right up by the diaphragm and I angle up and I can see those three beautiful veins coming into the IVC. So those are the hepatic veins. And it just looks so pretty to me. I don't know. Sometimes you won't get the left renal vein. And if you look, you'll get like a different kind of image where it's just the mid and the right. And it kind of looks like a bunny or like a Playboy bunny to be exact. So this is an A, that's a transverse view of the portal system. So transverse sonogram through the upper abdomen shows the splenic vein, which is SV, as it converges with the superior mesenteric vein to form the portal confluence, which is PC. And that's the beginning of the portal vein that goes into the liver, which is super important. In the other image, you can see the IVC there, and it's parallel. The SMV is parallel to that. And it's like another way of looking at the portal confluence. So all these veins like form the portal confluence. The portal vein system is huge. Normal flow going into the liver. We want it to be hepatopedal, which means forward flow into the liver. If it's hepatofugal, it's away. So how I would always think of that is a hepatopedal is you want to pedal towards the liver, and hepatofugal is like fungus, so you want to go away. I don't know. Everybody comes up with different stuff, but that's how I did. So that big vein is going into the liver there, and then it divides. into the right portal vein and the left portal vein within the liver. And you can see the IVC below it. This is another image that is just good to see how everything is connected. I really want you guys to learn this. I think this is so important, and this is kind of going to help you. Now, most of this should be review from patho or like anatomy, um, but it's going to be really important to know where you are and what the relation as you're scanning. So important things, aorta and IVC for sure. The hepatic artery anterior to the portal vein going into the liver. The splenic artery, you're going to see superior to the body and tail of the pancreas. And the SMA is posterior to the body of the pancreas, splenic vein, anterior to the aorta. And I'm not going to go over each one of these because you can also read. So I feel like it's kind of like we're doing this 2 times. So you guys can read that over. I want you to look at the relation. So our quiz on this is, which statement is true regarding the differences between arteries and veins? Valves are important for arterial blood flow. Due to the wall thickness, veins tend to maintain a consistent shape. Arterial walls are more elastic. And arteries depend on skeletal muscle contractions for blood flow. If you decided on C, you are correct. Arterial walls are more elastic, and skeletal muscles and valves are more important in venous blood flow to return to IVC. And arteries maintain close to a constant shape due to their thicker walls. Which arterial vessel is located posterior to the inferior vena cava? If you answered the right renal artery, you're correct. And I want you to know that. So make sure that you're putting that in your little stars. Which vessel is compressed in patients experiencing the nutcracker phenomenon? If you went with left renal vein, you are correct. So we're going to go over some pathology now. And of course, like if you're looking at this, you're like, oh my gosh, there's a lot. Lindsay's never going to stop talking. And that would be true. That would be true, except I'm going to pick one of the ones that I feel like is pretty important. All of these are important. I want you to look at all of them. But just I'm going to talk about one out of each section. So arteriosclerosis, important. It's part of, you're going to see it in the intimal lining, and I'll let you read more about that. But basically, it causes our arteries to be more jagged. And you have plaque. What I really want to talk about today is an aneurysm with the arterial abnormalities. So I think it's important. And I think all of it's important, but I want to talk about this. So, a focal abnormal dilatation of a blood vessel caused by a structural weakness in its walls. A true aneurysm involves all 3 layers. A false aneurysm or a pseudoaneurysm is an extravascular hematoma communicating with the intravascular space. So it's different. So the true aneurysm needs all 3 walls to be part of it. A saccular aneurysm is like a sac-like protrusion of the aorta toward one side or the other, usually larger than a circumferential and connected to the aorta by a channel or opening that varies in size. So what I want you to know about aneurysms, besides the definitions there, are most true aneurysms are either fusiform or circumferential. So fusiform aneurysm is a gradual progressive dilatation, which I feel like I've seen more as just like an enlargement in a part of the aorta. A dissecting aneurysm is when there's a tear in the arterial wall, allows bleeding to occur into the wall, which is scary. And I always did not really care for scanning those because I was afraid I was going to miss it. So um, they're kind of harder to see versus a fusiform pretty easy because it just gets enlarged, so you see a small aorta and then it continues to get larger, and so it's hard to miss that. So it's saccular and the circumferential aneurysms occur more in the abdominal aorta, and the dissecting aneurysms are less common and occur more in the thoracic aorta. So what we're mostly dealing with the abdominal aorta is going to be those first two. Now, another thing that I'd like you to know and remember is that most abdominal aorta aneurysms occur below the level of the renal arteries. So that's where you're really going to have to be paying attention for these. Here is another really good view of the three different types of true aneurysms: the saccular, fusiform, and circumferential. And the dissecting, which is like you can see part of it's just there's like a tear. Here's another. So A is a normal caliber aorta. B is an abdominal aorta with a mural thrombus. On the same patient, the mural thrombus has the parents present sign. So you can see how enlarged that is. And that's kind of what they look like. They just get big circles. Sometimes the blood flow doesn't go into the thrombus because it's just a lot of clot and blood. It's another way of looking at it. You always want to put color on your aneurysms. So I like F because it's like a coronal view again. So if I roll the patient on their left side, I'm scanning kind of on their side. So it is putting the probe on their side and looking through them that way. You're going to see the aorta, and then the arrows there are pointing towards the renal artery. So it's like your banana peel. And then below it, you can see like how it is, the aorta is enlarged there. So look at all that thrombus and how enlarged the aorta is, but how much blood flow there is. The thrombus and blood clots appear more of a gray white, while the black is more anechoic. Like, so you can see the difference there. All part of the aorta, however. I want you to go over aortic dissections. When you think of aortic dissections, I want you to think of Marfan syndrome. So put that in your head. Marfan syndrome is a syndrome that you can be born with. They have multiple things. They're taller, they have long arms, but when it comes to what we're thinking about, aortic dissect, they have a higher chance of aortic dissection. And I actually, there was a patient at our maternal fetal medicine clinic that was pregnant with Marfan syndrome, and she had a really high chance of mortality rate because she has such a higher chance of aortic dissection because of what she was born with. So it's kind of scary. Anyway, we're going to continue, although it's hard for me to do this. I feel like, oh, this is a good quiz. Which aneurysm involves all three layers of the arterial wall? If you answered A, you are correct. Which type of aneurysm is a gradual progressive dilatation of complete circumference of the vessel? If fusiform is correct. But you need to know all these. So I would look those up and quiz yourself on those. All right, you're going to keep going. I'm going to try to just touch on I mean, one of these, which is hard. So let's just go and let's do the most common type of the splenic artery aneurysm is a splenic artery. So a splenic artery can potentially also have an aneurysm. Females are more prone to it, and although it's not very common, it is life threatening. So I'm like, you can have an aneurysm of a lot of different arteries. And so this is looking at the spleen, which is like homogeneous and pretty, like a little bit different than the liver there. And you're going to see this enlargement because usually these vessels are pretty small. But if you see this enlargement like this, yeah, that's a aneurysm there. And then you can have aneurysms of the hepatic and of the superior mesenteric artery too. I will let you look over those. Which splenic artery aneurysm are most common? We just went over it. As splenic, right? Okay, so if you have an abdominal, like an aneurysm, a lot of the times they'll put grafts in. And you can see the grafts, which is really interesting. You can see the grafts in on ultrasound. So they're pretty cool to look at actually. So sonography is used to assess aortic grafts and related complications. Aortic graft, endograft, prosthesis is usually a man-made structure used to repair an aortic aneurysm. Look how cool they look once we get it. So they're like, you're going to see this is an aortic to iliac graft. And you can see like the ribbed echogenic structures around that. And that is the graft there, bypass graft. Sometimes you'll even see this. You'll see two limbs within the aneurysm. Look how big the aneurysm was. This is huge. That's the whole aorta. So they are going to graft it and make the blood flow through the graft to repair that. So when you do have an abdominal aorta there or aneurysm, you get a graft, there's going to be complications. It seems like there's always complications to stuff. And one of the things that they look for is leaks. You could get pseudoaneurysms, graft aneurysms, hematomas, abscesses, occlusions. So, things can go wrong with the graft. So endo leaks, transverse wise, you're looking at it in picture A, that's a sac with a circle, and the limbs are identified. And then you can see the color flow in both of those. And you see like there's blood, a little bit of blood where that arrow is outside of the limbs. That is not good. That means there's a leak. And it's kind of what a leak looks like a up and down flow. So which of the sonographic appearances are characteristics of an aortic graft? A, refraction artifact with shadowing. B, wall brightness, possible ribbing. C, curved vessel wall. Or D, a to and fro pattern. If you said B, you're correct. You're going to see wall brightness and then possible ribbing, which is those little dots around the the aorta aneurysm. Which aortic graft complication is suspected if duplex Doppler cannot confirm the presence of a blood flow? Well, we didn't necessarily go over this, but let's just think about it. Probably if there's no blood flow, it might not be an abscess. It's definitely not an endoleak because you're going to see blood flow during that. Graft aneurysm doesn't really make sense in this, but an occlusion does, doesn't it? So D, occlusion. The absence of the flow denotes occlusion of the graft. If flow is not present with arterial pulsations, the absence of flow is most likely occlusion of the graft, which does happen, unfortunately. We do a lot of vascular work for stenosis. And we're going to talk about like the most common one that we do, which uh, are renal artery Dopplers for renal artery stenosis. So basically, what stenosis is, where the vessel lumen narrowed by plaque or different changes. You're going to see post-stenotic dilatation, increased velocities in the area of the stenosis, and downstream changes. So, like turbulence, decreased velocities, slowed acceleration, and relative elevation of the diastolic velocities. So, here is a normal Doppler waveform of the aorta. And you can see how it's like a high stroke and then it's low. So it has like a lower diastolic flow. While a lot of the major branches of the celiac arteries, they have like less higher stroke, but like the diastolic flow is higher, which we'll learn more about that. The superior mesenteric artery in C supplies the small bowel and the proximal colon that also has a low resistance arterial beds. The arterial waveform is affected by prandial states. So if you're eating, it's going to be different than if you're MPO or fasting. The hepatic arterial system is also lower resistance. So in this patient, the examination shows the normal low pulsatility of the right renal artery. Doppler spectrum seen in the PSV, so the peak systolic velocity, how high the peak is there is 110 cms per second. That's how fast the blood's flowing through. And forward flow is present in the diastole is because of the low resistance flow of the renal vascular bed. So you're going to have a higher diastolic flow. So now we're going to get to renal artery stenosis, and it's usually caused by plaque, generally located at the origin or first 2 centimeters from the aorta. So a lot of the times you're going to see like the stenosis right off the proximal aorta. It's difficult to tell a lot of the times. This is like the hard part about doing these kind of vascular studies on an abdomen is because you're dealing with a lot of bowel gas and you're dealing with like patient's body habitus. So a lot of the times if a patient has a larger body habitus, it's difficult to penetrate enough to really like examine and evaluate the renal arteries how we should. Now, sometimes you'll get so lucky and you'll get that patient and you can just see both branches coming off of the aorta and it's just gorgeous. And you can, Doppler at every single section that you need to. And it's wonderful. And you feel like you got a good study. But a lot of the times, these renal artery studies, they are limited. And I don't know how many times I put like limited study due to body habitus, or something like that, or bowel gas. But you still try to do your best. So when a renal artery, you do have renal artery stenosis, you can have hypertension. So if there is a patient that has like just uncontrolled hypertension, they look at the renal arteries to see if they could potentially there would be narrowing in one of them causing that. So there's two methods that you can use to evaluate renal artery stenosis, or you can combine them, which usually is what happens with me because I'm trying to scan a patient that I can't see all that I need to see. So the direct method relies on detection of blood flow changes that occur at a hemodynamically significant stenosis. And the indirect method relies on identification of blood flow changes that occur distal to the significant stenosis. So you kind of, both methods require attention to Doppler technique being crucial to the examination. Here are some direct and indirect things. So if there is direct evaluation, if you see narrowing and the peak systolic velocity, so the high, the peak, how when we measure that, if it's greater than 180 to 200, that is a way of telling that there is a stenosis there. Or when you do your renal to aorta ratio, and so you also do a velocity of the aorta and then you divide it. And if it's 3.3 to 3.5, then there's a stenosis. And that's a way to tell that. Indirect ways of telling it is a little bit harder. So absence of the end systolic peak, the acceleration time of the velocity below the stenosis is going to be 0.07. A tardus parvus waveform, which is a lower, it's not a high peak fast. It's like it takes a long time to get up to the peak systolic velocity. And then an RI difference, so resistive index between kidneys exceeding 5. Sometimes when you do get where you did see the narrowing and you Doppler at that point, you're going to get an aliasing flow, which means that like here you can there's flow on the top and there's flow on the bottom, and no matter how much you turn up your different areas of the machine to kind of help get you a better baseline and get you a better where you can be more diagnostic, it just seems like it's just aliasing, so it is you can never really get a good peak systolic velocity, and that is a sign that there is a stenosis. We are going to continue on here. So in C, this is what I'm talking about, like tardus parvus flow. So it's very low diastolic and then it takes a long time. Come on, you got to get up that hill and it just takes so long to get up the hill, and then it's more of a rounded flow and then it goes back. So it's more like hills instead of mountains. And D, that's more of a normal intrarenal flow. And I'll let you look at stent imaging because I know this is taken forever. I would go over and be pretty familiar with mesenteric artery stenosis too, and what happens with that. There's a lot of pitfalls. Yes, there is a lot of pitfalls. Okay. Okay, we're just gonna get past this because I was trying not to keep you guys too long. This is an important chapter. I would highly recommend that you get started on it. So venous abnormalities, I am going to talk about, I believe, although all of them are important, hepatic venous abnormalities or portal venous abnormalities. Both of those are pretty important. So we're just going to go down to that. So hepatic venous abnormalities, Budd-Chiari syndrome, is basically where there's occlusion of all or some of the hepatic veins. And that's what you need to know for that at this time. So if you see the hepatic veins and it looks like there's clot in it, you put blood flow on the hepatic veins. So you put blood flow on the Playboy bunny, and you don't see any blood flow from the IVC to the veins, then it could be the syndrome. And then the body has to come up with collaterals or other ways of getting the blood flow. That's pretty interesting. But for right now, that's just what I want you to know about that. Let's talk about portal vein thrombosis. I feel like I see this is pretty important and I've seen it more than anything else. So that's why I'm kind of picking this stuff out. So it can be caused by a variety of pathological states, portal hypotension, inflammatory abdominal processes, so appendicitis, peritonitis, all those things, trauma, post-surgical complications, hypercoagulability, if someone's oral contraceptives, pregnancy, that kind of stuff, renal transplant, ulcer disease, or it can be idiopathic. A potential complication of portal vein thrombosis is bowel ischemia and perforation, which is not good. So image A is a grayscale image, demonstrates echoes within the main portal vein as it enters the liver. So you can see there's a little bit of gray at top on that vein. So there, there might be some clot there. B is the color Doppler image, shows a filling defect consistent with portal vein thrombosis. So there is some clot in there. On a different patient, the transverse image displays an echogenic clot in the portal vein, which is kind of spooky. So what happens, there's an increase in portal venous pressure. So a normal portal venous system is sustained around 0 to 5 milligrams Hg. When there's portal hypertension, it goes up to 10 to 12. In more advanced cases, there could be ascites and GI bleeding. So you're going to see anechoic fluid around the liver. So to diagnose portal venous hypertension, it's important to look for secondary effects of increased pressure. But we can note the clot, but there's no really established rule in Doppler sonography. Yes, there's a clot there, but there's no way of us really helping diagnose that at this time. Which of the following describes portal venous pressure of 10 to 12? You did portal venous hypertension, you are correct. All right, we're almost to the end. And I'm sorry I have not gone over everything, but I just know that you guys are going to do so good reading and workbook. And if you have any questions in the discussion, or really something's not making sense, I want you to make sure that you talk to me about that in the discussion, ask me questions, and we can go into further discussion about stuff. For this one, I'm going to talk about TIPS, which is transjugular intrahepatic portocystic shunts. So shunts, they help connect something if there's like a stenosis or a clot and there's not blood flow. We're going to go in with a shunt and it's going to be like a bridge between the vessels to help get the blood flow going again. One of the ones that I did a lot when I was in the hospital are transjugular intrahepatic portocystic shunts or TIPS. So basically, there's a shunt. The TIPS procedure involves placement of a metal stent between the hepatic vein, you remember our Playboy bunny sign, those veins, and an intrahepatic portal vein via a transcatheter route through the jugular vein. And TIPS is usually easily seen as a bright tubular structure within the hepatic parenchyma, connecting portal vein with one of the hepatic veins. So it's pretty easy to see. Any kind of graphs or stents are really bright, so they're easy to see. Complications include stenosis at either the portal or hepatic vein, anastomosis, or inclusion of the shunt. Sometimes it does happen that we do the stent does occlude. So our role in it is, well, there's quite a few roles in it. We do pre-TIPS ultrasounds where we're looking at the portal blood. And then we can help assist with the TIPS insertion into the jugular vein. We don't have to stay for the whole vein, but they just want to make sure that it goes into the jugular vein. And then post-TIPS ultrasound. So after they have gotten the stent in, you will scan again to look at the blood flow and to see how it's looking. And you can see the TIPS there where it says TIPS and it's normal color Doppler. And then this is another TIPS that is having some narrowing or there's some kind of occlusion happening and it's significantly elevated velocity. So anytime you get like a really bad narrowing, you can see that the pulse wave Doppler looks messy because the blood is flowing so high at high velocities. It's hard to get a good accurate peak systolic flow because there's aliasing, there's to and fro flow so fast. So our pre-TIPS examination includes measurement of the maximum blood flow velocity at the determination of the blood flow direction within the extrahepatic portal vein, SMB, splenic vein confluence, and identify collaterals and blood flow direction within. So, and then post-TIPS, you do the same thing, plus evaluate the shunt in 3 places. And usually, when you're doing TIPS in the hospital, if you are working in the hospital, they'll show you how to do this. And then I always had my little protocol written down. And then then I got pretty used to it and was able to just remember what to do. And that goes for all your protocols. So I'm not going to go over every single one of these, but these are just more protocol and criteria for evaluation and TIPS. Which Portis system shunt was developed to avoid the surgical risks associated with other 3 shunts? If you answer transjugular intrahepatic portocystic, you are correct. And that's it, folks. So we made it through. But I know this is going to be like, you're going to do so good. You're going to do so well on this chapter because you're going to read it. You're going to take notes and you're going to focus on the things that I told you about. And for right now, that's great. Like my husband says in all of his meetings, you have to, I guess, I don't know why he says this, but you have to eat the whale one bite at a time. I he has a lot of business weird stuff he says, but I was like, okay, it makes sense. Like this is a big old well, like abdominal vasculature is a big old well for a young guppy fish as you guys are right now. So we got to focus on a couple of things that are really important right now, and as you grow, we can get more into it. So I hope this was helpful, and I hope you have a good week. Bye bye.